Good morning. You are very welcome to participate at this British Heart Rhythm Society virtual webinar hosted by Radcliffe Cardiology. I am very pleased to introduce my delighted speaker, Matthew Swift from Great Trust Hospital, who is going to tell us the very important new aspects of management of device recipients in the post-COVID era, a situation where we had to face a new challenge and adapt to a new organization model. Please, Matthew, I'm very happy that you can tell us about your experience and the strategies you are now using in this new challenging scenario.
Thank you, Professor Biffi. Just for those my name is Matt Swift. I'm the lead cardiac physiologist for devices at the Great Western Hospital in Swindon. We're going to talk to you today about how we've managed our remote follow-up device service during this period where we've had the COVID pandemic. Little bit of history, we've offered remote monitoring to all our device patients since 2010. The main reason for going down this route was that we really lack space in our centre, and we found it very difficult to see all of our device patients within the British Heart Rhythm Society guidance timeframe. Currently, we've got 4,000 patients enrolled in our remote monitoring service, and since we started in 2010, we've performed 30,000 remote device follow-ups, and in the last financial year, 2019-2020, we managed 19,000 remote device alerts that came through our remote monitoring systems. So first of all, we'll just go through some of the controversies that surround remote follow-up, which often put a lot of other centres off going down this path. So we're going to look at threshold checks. We're going to look at some of the things that we normally would detect in clinics, such as heart failure and how we could detect those via remote monitoring. We're also going to look at wound infections if we're not seeing the patients face-to-face. So threshold checks, is it safe to perform remote monitoring where we're not seeing the patient yearly to perform threshold checks like we used to in the olden days? Well, most modern devices have beat-to-beat auto capture algorithms which perform these threshold checks daily, and they're actually performing the checks on a beat-to-beat basis. If we do lose capture, you need to ask yourself which is safer, to have a 5 volt at 1.5 millisecond backup if loss of capture is detected, or to have tested the threshold once over a 12-month period. In our experience, over 10 years, we've had one adverse event of use of a fully auto capture algorithm in the remote monitoring, and this was due to a lead issue on a particular device. When we look at which patients we want to put onto remote monitoring or to continuous remote follow-up, it's important that we use auto capture algorithms to ensure that to ensure the integrity of the leads. But what we must also be careful of is where auto capture algorithms do work, where auto capture algorithms don't work, is that we're programming the devices properly as per the implant indication. If say an atrial auto capture doesn't work in a patient with complete heart block, unless they've been medicated or are unlucky to have sinus node disease as well, they have no pacing indication in their atria, so we would normally set these patients DDD40. And even if we can't put atrial auto capture on, we can still follow them up remotely safely. It's also very important to minimize right ventricular pacing in patients where it's not required at all.
Matthew, may I put forth a question? As you touched a very sensitive step, that is, we need to take advantage of this highly reliable technology, but meanwhile you use automaticity, you verify and check every time that the patient has a tailored programming. So I see that you have a large experience. I love this approach, and it emphasizes the role that the physiologist has as a interface between the long-term follow-up of the patient and the implant in the operating room. Mm-hmm. So, my point at this level is the physiologist is a professional figure that is not available everywhere in Europe. UK is kind of unique in this situation, and we should probably emphasize more and more the importance of dedicated people like yourself that test and verify daily that what is assumed to be working in the device actually works. So to me, it's a really important thing what you mentioned right now. Take advantage of all the technology, but be sure that it is working. Do you agree that your professional role here is not going to change with the COVID pandemic, but indeed is going to be strengthened and possibly imported into realities where it is not working today?
Yeah, I'd say that's very true, Prof Biffi. I think what this has shown, the COVID pandemic, is that the follow-up of devices, both remote and in clinic, they are interdependent of each other, in that some patients can have continuous remote follow-up, some patients require follow-up in clinic, and it's where these patients cross over and where the crossover occurs is where the skills of the physiologist and the medical team are most required.
Thank you. Absolutely true.
So detection of patients who are going into heart failure or decompensated heart failure. If we see the patients in clinic, we can analyze them in a face-to-face nature. We can do an end of bedogram to look for ankle swelling. We can question the patients. How many pillows have you slept with? Or simply just ask them how they've been. Now, the signs and symptoms of heart failure can actually be very subtle. And the European Heart Journal and the EHRA guidance says that they should only be performed by someone who's been suitably trained in their detection. So at our centre, we work very closely with our specialist heart failure nurses. And if we think of any patients in clinic we think maybe going into decompensated heart failure or in the middle of a heart failure episode, we will call the specialist nurses in to assess them thoroughly. Modern devices have a lot of diagnostics that record information through that can actually point us towards patients that may be about to or be in the middle of a decompensated heart failure episode. These include thoracic impedance monitoring, patient activity levels, their AF burden, heart rate variability, and their percentage pacing, increased right ventricular pacing or decreased biventricular pacing. So this is how we work our system at the Great Western in Swindon. So we look out for the diagnostics which are listed around the heart, and if we see 2 or more of these diagnostics, we will refer the patient to the heart function team for them to contact the patient, see how they are, maybe bring them into clinic or see them in the community. And this has been very successful, requires quite a little bit of work and management of the alerts, but this information is coming through from our remote monitoring systems daily, and it would be a shame not to use it for the benefit of patients.
Matthew, I have a question about this. Normally we are using more and more the diagnostic information from the device to manage the patient. And what you mentioned is quite common, that we have data that are not straightforward diagnostics, but should be implemented into, let's say, patchwork where pattern recognition is sometimes difficult to put on signs and symptoms. Do you ever work with a questionnaire that you deliver to the patient, or that you ask the patient after you see an alert coming in, and run through a multiple questionnaire test, just like 10 questions, just to increase the specificity of the device alert? And if you do that, how do you feel comfortable with that? Is something you can do via a video call, and this does not frighten the patient? What is your experience?
It's not something I've used personally, because we work closely with the advanced heart function nurses. It's something they tend to do. But further on in the presentation, you'll see that we are moving towards using video technology to do remote face-to-face follow-up. So it's something that we will definitely be looking at, how we question these patients, and systems that we use to tease out any symptoms, what precipitates the symptoms, what's the alleviating factors. So it's something I think that we will add to our practice within the next 6 months.
I do believe that this is important because with the patient, the more you ask, the more you get. So indeed, if you can take 5 extra minutes and question them properly, you may increase the diagnostic value. So I'm happy that you say I'm willing to change my activity in a few months. Very important. Thank you.
Thank you. So this is a patient I actually found this morning on the remote monitoring clinic, and I've added it very quickly into this presentation. So this is a patient who has been hospitalized with COVID around the time of late March. And you can see that there's a very clear change in their, it's a Medtronic device, their Optivol, the thoracic impedance monitor. They've had a huge drop off in their patient activity and an increase in their mean ventricular rate and a reduction in their heart rate variability, all pointing towards an episode of decompensated heart failure as a result of COVID-19. Unfortunately, because this patient was admitted to a sister centre, I haven't been able to get hold of any imaging pictures or any echo, which would have been interesting. But I thought it was an interesting diagnostics to put into the presentation all the same.
Very true.
Late wound infections. A lot of other physiologists that I speak to worry about wound infections if they're not seeing their patients in clinic. From my experience of 10 years of remote monitoring, we very rarely missed any wound infections. This large study from Denmark of nearly 46,000 patients showed that the risk of late wound infections is actually very, very small. The ones that tend to come to us have already presented to their GP with another issue, but it's very important that we educate our patients as to what to look for with their wound and the way that their device should sit in their chest. And we also send letters as part of our clinic structure to the GP clinic, to the GP service, so that every time the patient comes into clinic, the wound is assessed.
This is another very important aspect, that is many of the perceptions that what you don't see does not exist. My habit in this perspective has been to ask the patient to send a picture of the pocket of the device at regular intervals. So as I'm not seeing many patients since years, just like your own practice, I need to have, for instance, a picture every 12 months. And now with this pandemic, it's more important. You mentioned that you are going to move to a video-assisted remote follow-up, and that would probably clear us off of this trouble.
Yeah, so our current practice is that we see patients 2 weeks post-implant, where we will inspect the wound and see its sort of an initial healing. And then after that, we don't see them at all, if we don't have to. Now, with the pandemic and this new technology being available to us on the National Health Service to be able to remotely follow patients up, I think this will vastly improve the way that we look after our patients' wounds. So this is the British Heart Rhythm guidance for device follow-up, which was released in February. This mimics pretty much the service that we have got at the moment at the Great Western in Swindon, where Brady patients, if we're happy that they're stable, we can see them virtually. ICD patients are often the ones that most like to be on virtual only follow-up. People who have primary prevention ICDs, borderline 30% ejection fractions, often don't know that they actually have an issue, and they like to just be kept at arm's length. But I think it's important that we must remember that CRT patients and patients who have physiologic pacing, hip bundle pacing, left bundle branch pacing, these require in-clinic follow-up for them to be optimized. So we see those patients remotely at 6 months and in clinic once a year.
Yes, this is our practice as well. I wonder, what is your habit when you see those patients who have a ventricular tachycardia terminated by ATP? this is not a dramatic episode, just like having a shock for the patient, but it's something that you will know, even though the patient is totally unaware. What is your role at that point? Because I imagine you deal with the doctor, but do you schedule a follow-up, or do you ask, again, questioning just to understand whether there is anything changing in the medication, stuff like this?
Yeah, so the results of the ATP episode will be forwarded on to their clinician in charge of their care to review their medication. And they always are followed up with a phone call as well, just to see if they had any symptoms around that time, and just to double check how they've been getting on, have they been taking their medication correctly. And also in the UK, we have the issue with the driving. So if you have symptomatic ATP, you have a 6-month ban from driving. So we phone the patient to make them aware of that.
This is another important role of the physiologist in detecting that this is a appropriate ATP versus an inappropriate one, or an unnecessary ATP delivery on a supraventricular tachycardia. So that's very important. You pinpointed that whereas ICD patients have been the most likely to be enrolled into remote monitoring, pacemaker recipients are less frequently receiving remote monitoring, maybe because they are elderly, in your opinion, or maybe because they have device releases that do not support remote monitoring?
Yeah, I think one of the largest barriers to pacemaker follow-up remotely that exists in the UK is cost. I think it's the higher end pacemakers tend to carry the remote monitoring functions for automatic remote monitoring. And a lot of the times the accountants of trusts will question as to whether it's actually required. So I think that is a large stumbling block for a lot of centres that want to start to remotely follow up their patients. I know when we started to follow up our patients remotely, our pacemaker patients, we had to put together a large business plan, with a lot of information and statistics as to how this would actually be a benefit financially to the trust.
I realize. What's the UK policy for the reimbursement of remote monitoring? Is that different for a pacemaker or an ICD? Or do you get the same revenue, whatever the device you are following remotely?
I think it's the same. I think. I'm not 100% sure, to be honest. It's something that someone could maybe clarify for me. But yeah, I'm not 100% sure, to be honest.
In my country, it's just the same. So yeah. That creates for us a barrier, because it's not really worthwhile to sustain the cost of remote monitoring if this is not reimbursed adequately. So for us, it is a barrier, and that should be some way dealt with in the so-called system, not at our level, I realize. Mostly, I find that it is interesting that we all face the same issues, and especially the accessibility of a very busy outpatient clinic for device monitoring today is a challenge that can be dealt in a smarter way, just like remote monitoring. And we have learned that starting from there, we can remotely make a patient assessment instead of a device verification. And that was a major step forward from the 10 years of experience that you brought into the picture today. So my conclusion is that we need more and more sophisticated and smart approaches to deal with the patient today. And that probably brings in the video-assisted follow-up and some questionnaire that can be administered to dive into the patient's symptoms and physical signs that you can observe, so a pattern recognition can be put forth, and you can have a suggestion to send the patient to the right clinic. I mean, it could be heart failure and you refer it to a cardiologist, but if any is suspicious, you might refer the patient to a different clinic, just like pneumology or internal medicine, because the patient is anemic or whatever. But what is important is that there is a team of professionals that make the first assessment. And it has been, the history took the first path at your step. That is, the cardiac physiologist was the first one engaging into this new model of medicine. And it's really important that you told us such long experience today. Thank you, Matthew.
Thank you very much. So the COVID-19 pandemic has thrown up some challenges for us based on the government's guidance of what to do, especially during this lockdown period. The number one thing most important in our minds is to keep our patients safe, and that has led to us having to reduce the number of in-clinic visits to almost to zero. Of course, keeping our patients safe is one thing. We also need to keep our staff safe and well.
Yeah.
We've been lucky in that we've been doing remote follow-up from home now for the entirety of the time that we've done remote monitoring. So we are well set up for it, with secure remote access servers, paperless system. So all the information we require is at our fingertips.
Matthew, may I ask you, for the inpatient follow-up, those who need to be seen in the outpatient clinic, how you are organizing the patient flow? That is, do you have a waiting room? What is the patient shielding in the waiting room? And what is your approach at protecting yourself? That is, the physiologist and the medical team. How do you do that?
So, answer your question, Professor Biffi, we're running a 2-clinic site service at the moment, where we have the main hospital, the Great Western Hospital, which is on the left of the screen, which has, obviously, as a district general hospital, the usual amount of COVID positive patients stationed there. The hospital on the right is what is actually the private hospital just outside Swindon. So we have got some clinic space within there, and we're seeing our patients every hour, at hourly intervals, our device patients. And when they come in, they're assessed by a nurse for temperature, and they're questioned as to whether they may have contracted coronavirus. And only when we're happy and the nursing staff are happy there, that we will actually see them face to face and perform their clinic checks. We're just using in that clinic basic PPE as described by Public Health England, with an apron and a fluid-resistant surgical mask.
Okay, seems very wise to me and very well organized. It's something that we can recommend to any other center who is approaching this task in the next months.
So this is, we locked down in the UK on the 24th of March, but we got ahead of the game in our department by creating this algorithm of how we were going to deal with our patients, our device patients, during this pandemic. And the main goal of this, as with everything, is patient safety. So what we decided was that any patient who has a remote monitoring device, has underlying rhythm or auto capture, their next appointment will be remote. The only patients that we actually are seeing in clinic are those who we are 100% dependent on their device, and have a clinical need to come in. So they've had, say, unsuccessful ATP, they've had ICD, they've had VT below their detection, and they need to have their detection changed. But it was something that we implemented, and myself and one of my colleagues went through 2 months worth of our patients, applied this algorithm to them, and moved their follow-ups around.
Yeah, there's a subset of patients that indeed trigger an inpatient follow-up, just like those who have episodes, as you mentioned, or they have a high rate atrial episodes being detected by the device. So you might have to reevaluate the stroke risk and change medications. And of course, these are patients that we need to take out, and the algorithm that you are proposing clearly picks them out of the remote part of device follow-up to be medically evaluated. I dare say that your view is quite comprehensive of what is the real world of the device recipient and of the many interconnections that they have with other medical morbidities. So it's not one small window on life, but it's a large window that the device opens. And we need to be very careful and proactive to react and work for the patient's sake. So it's a really important experience, this one.
Absolutely. It's all, from my experience of looking at these patients, and we looked at, every single patient we had due in over a 2-month period. So it's 600 odd patients. And we looked at them on an individual case-by-case basis to decide the risk and benefit of them actually coming into the hospital or going to our clean clinical site at the private hospital. So it's all, patient safety was first and foremost.
I do believe that this is an important thing. This is a great thing that we balance the risk of doing either before a prescription of you come or you stay. So very wise.
So this is the way we've been doing our wound checks that we discussed earlier. So this technology has become available on the NHS within the last few months. So at the minute, it's something we're just starting out with. Our implant numbers are lower at the moment, obviously, because we're only implanting emergency devices. But we're using this video consultation technology, which is available and free to everyone within the health service, called Accurex Fleming. And that's what you get on the screen there, is you're able to see your patient. It works via smartphone or via laptop. So we assess our patients at implant to see if they have the technical savvy to be able to use it. If they haven't, or for some reason they don't want to use it, at the moment we're phoning the patient, we question them on the wound condition, and similar to your practice, Professor Biffi, if there's any issues, we're asking them to send us an image via email, and that's a hematoma there that we got from one of our patients who had an implant a few weeks ago.
This is an important topic you are touching, because everything that comes via the internet raises the issue of privacy. And this is mostly burdening our profession, because if you speak to the elderly patients in our practice, they have little worry about a picture of them being sent over the media. Whereas this may change for younger patients or patients whose occupation requires a strict protection of privacy. So I dare say this is a very sensitive item. Probably, this is what I was going to ask you. We should be able to obtain a protected communication channel when we are doing remote assisted medicine, especially with video, but also with conversations, just to protect the patient privacy, because some questions may be overheard and this is not worthwhile to happen. So what I was doing to ask you is, does this communication system provide you also a encrypted channel of communication between the clinic and the patient, or do you think that it can be overheard over the internet?
To my knowledge, it is secure. It's marketed as being secure, and it's been backed by the NHS.
Great. Okay, means that someone took care of this. That is, that this issue was clear in the backstage of the mind of those who delivered that to you.
Yeah, absolutely. And you need an NHS email to log in, and those, an NHS.net email is encrypted as well and secure.
This is miles ahead of many other countries. And I dare say it was very sensitive to care about this because it really enables remote medicine management because you have protection. At least nothing is really safe, but this is the top level of safety that we can afford today. So if I were a UK patient, I would most likely use it because it saves time, money, and indeed is a safety key because you can, let's say, enable a closer follow-up for those patients where when you are in doubt. I can reevaluate the patient after 7 days, for instance. I guess you can do that. So this increases the safety for the patient. Very important.
This is just a brief overview of what we did in April of this year during the lockdown period. So we only implanted 16 devices, 15 of which were pacemakers and one ICD, one emergency ICD in a patient. But as a department, we performed 485 device follow-ups, 25 face-to-face, either in the main hospital or in our clean hospital, and 456 remote device follow-ups we performed in that month. And compare that to last April, we're working at 97% of our capacity from last year. So continuous remote follow-up is safe and efficient, and we must always regard it as complementary to in-clinic follow-up, by event optimization, taking of 12 leads, echo optimization, things like that. It allows us to utilize extra space and time and staff for our cardiology departments, which are often saturated. It creates clinic space for patients who need enhanced follow-up. There is a lack of face-to-face interaction, but this is improved by video technology, as we've discussed a couple of slides ago. And it's vitally important to use remote monitoring during these uncertain times to protect not only our patients, but also our staff.
Absolutely. Thank you, Matthew, for your excellent review of this topic. For those who are going to access this virtual webinar, there are several take-home messages that are really key for the management of patients in the future. That is, remote technology is absolutely safe and effective for the device and promotes patient management as well. Beyond what Matthew told you, it increases the safety of device management and can increase the safety of patient management because alerts trigger medical reaction much earlier than what is detected at the regular device follow-up in clinic. So having also the possibility to have a dedicated, protected communication system with the patient, I dare say that this is a milestone for the development of remotely assisted medicine. And I thank you, Matthew, for his participation to this program.
Professor Biffi.